hope I don't spill my tea. Maybe I'll put it over here.
I'm a little worried about ruining bows.
Okay, so for today's lecture, we're going to start off talking about just a little review about neuroanatomy, and then we're going to go and start talking about local anesthetics. Now, when we talk about local anesthetics, we know that local anesthetics all contain anesthetic. Some contain a vasoconstrictor as well. We're not going to focus so much on vasoconstrictors today because we'll talk about those next week, all right? So today we're just going to focus on specific anesthetics and how they work, okay? So just as a review, we have three different types of neurons, or there are three different types of neurons. There's the unipolar, the bipolar, and the multipolar. Unipolar are the ones that are found in insects. Bipolar, we do have a few bipolar neurons. They're found in our retinas. And the majority of our neurons are multipolar. If you look at a neuron, you're going to have a section where you have a lot of dendrites. The dendrites are the structures that will find the impulse or find the stimulus and bring it to the cell body. The cell body will then send that impulse down the axon to the axon terminal. The neurotransmitters then would be found down here. So the neurotransmitters would be released so that they could then go to another neuron or to a muscle or to a gland. So we have a dendrite zone, we have the axon, and then down here we have the axon terminals. Now, nerves may or may not have myelin on them. The myelin sheath, if they do have one, is produced by the Schwann cells. If you look at the axon of the neuron, you can see that there's little openings or little breaks within that myelin sheath. Those little breaks are called the nodes of Ranvier. And what happens is, as the nerve impulse or the action potential is sliding down that axon, it actually bumps from one node to the next. And that process of bumping down the axon from one node to the next is called saltatory conduction. So all saltatory conduction is that it's the bumping of that action potential or that impulse down the axon as it bumps from one node to the next. So would you have saltatory conduction on a non-myelinated neuron? No. So when we anesthetize someone, we're going to create a loss of function. And there are different functions that can be lost, and they're lost in a specific order. So when we anesthetize somebody, we want to relieve them of pain. So the first function that is lost when we anesthetize someone is pain. As the anesthesia becomes more profound, they will lose the function of determining temperature. So for those of you who've worked in dental offices before, when someone is anesthetized and they say, oh, I still feel cold, that's because they haven't lost this function. They may have lost this function, but they haven't lost the temperature function. As we progress further, they lose the function of touch. So if you touch the area, they won't be able to tell that you're touching it. Pressure is next. How many times has someone said that's not pain you're feeling, that's pressure? Okay? And then next is proprioception. And proprioception is the brain knowing where a specific body part is. So a good example of this is I had shoulder surgery. And I ended up having a frozen shoulder, and I had to have another surgery to open up that frozen shoulder. When I went to sleep, my arm was next to my body. When I woke up, my arm was over my head. But my brain was telling me that it was next to my body because that's the last thing I remember. And I had lost the function of proprioception, so my brain had no idea my arm was over my head. And so I could feel someone touching certain areas, but there was nobody around me because I thought my brain was telling me my arm was next to my body. So I'm like, why am I feeling somebody touching me and there's nobody there? Well, that's because they were behind me. Okay? And then the final one is motor. Now, sometimes this loss of function is not exactly in this order. So you may have someone who can feel pressure, but they don't feel, like in my case, I could feel the person touching my hand, but my brain had no idea where my hand was. Okay, so it doesn't always follow that in that line, but typically you're going to see the loss of function occur in that order. Now, when we anesthetize, we typically don't get to this full level because when we anesthetize, we're anesthetizing certain nerves, but there are other nerves that are around it that we may not be catching. So even though we're relieving them of their pain when we're doing the work on them, they still might feel pressure. They know where their tooth is, and they'll still have motor function. They can, you anesthetize their tongue, they still can move it. Okay. Now yes.
So for the exam, should we know each what comes next?
You just need to know that there is the loss of function. Okay. Now, when the function comes back, it's going to come back in the reverse order. So, if someone loses all of these function, the first one that's going to come back is the motor function, and then the proprioception, and then eventually the pain will come back. Okay? So now we're going to look at what happens when we stimulate a nerve. So we know that when a nerve is just sitting there waiting to be stimulated, it's in its resting potential. So if we look at this, this is a cell membrane. Okay? Don't get caught up in all of the garbage on here. Just realize this is a cell membrane. When the neuron is in its resting potential, what we will find is that in the extracellular environment, there will be a large number of sodium ions and a large number of chloride ions. That's in the extracellular environment. In the intercellular environment, or the cytoplasm, or the axoplasm, whatever you want to call it, there is a low amount of sodium and chloride. So the majority of the sodium and chloride is outside of the neuron, very little on the inside of the neuron. Also during resting potential, inside the neuron, there's a high amount of potassium. And then outside, there's a very low amount of potassium. So during resting potential, the sodium and chloride, the majority is on the outside, and the potassium, the majority is on the inside. That's resting potential. Okay? All right, so this blue block here is a neuron. This is the extracellular environment that has that sodium and the chloride in it. This is inside the neuron where we have the potassium. So, stimulus comes along and the nerve depolarizes. When the nerve depolarizes, what happens is the sodium moves to the inside of the axon. So it moves inside the neuron. The chlorine follows, or the chloride follows the sodium. The important part is the sodium. So during depolarization, the sodium enters the cell and the chloride follows. As this occurs, the action potential slides down the axon until it gets to the axon terminal. So as the action potential slides down the axon, the sodium will be coming into the cell, and that's what propagates that action potential. Everybody following me with that? Okay. So now we have a cell that's depolarized because it has the sodium now inside. Once that occurs, the cell will then go through repolarization. During repolarization, the potassium that was inside the cell goes to the outside. So during depolarization, the sodium goes in. During repolarization, the potassium goes out. Once this occurs, we are now entering a refractory period. During the refractory period, the cell cannot depolarize again until it goes back to its original state. So during the refractory period, we have to somehow get this sodium back out and we get the potassium back in. Now they won't go on their own. So we have these pumps, and the pumps will actually push the sodium back out of the cell and pull the potassium back in. So that occurs during the refractory period. At the end of the refractory period, we now have all of our sodium back on the outside, our potassium back on the inside. Now this cell is back to its resting potential. During a resting potential, the extracellular environment is positively charged. During resting potential, the inside of the cell is negatively charged.
Can you say that one more time?
During resting potential, the extracellular environment is positively charged. During resting potential, the intercellular environment is negatively charged. Okay? So now we're at a resting potential again. This cell can now be depolarized. If it gets another stimulus and it depolarizes, again, we'll see the sodium going in. During repolarization, potassium goes out. During the refractory period, the pumps start working. The pump pushes the sodium back out and the potassium back in, and the cell is back to its resting potential again. All right, everybody follow me on that? Okay. So now that we understand how that works, we can now understand how local anesthetics work. So when we look at these cells, again, we have the cell membrane. There is a sodium channel. So remember, the sodium has to go into the cell in order for the cell to depolarize, right? So it goes through these channels. So the way that the local anesthetics work is that they're going to block those sodium channels. When they block those sodium channels, it prevents the sodium from entering the cell. Unfortunately, it doesn't just block it from the outside. The anesthetic has to get inside the cell, then it blocks it so that more sodium can't get in. So we'll look at how that works here in just a second, okay? So it's not that the anesthetic is just putting a barrier right here which prevents the sodium to go in. The anesthetic has to get into the cell, block it from the inside, now the sodium can't enter the cell. Okay? All right, so before we get into that, we're going to look at the difference between injectable preparations and topical preparations. Injectable means that you can use a needle and inject the solution. There are two different types of anesthetics. There are esters and there are amides. Now, when people talk about Novocaine, Novocaine was used years and years and years and years ago, and Novocaine was an ester. The problem with esters is that they must have a preservative in them. And a lot of people had hypersensitivity reactions to that preservative, specifically PABA. So there was a greater incidence of toxicity with these medications because hypersensitivity reactions are toxic reactions. So we no longer use injectable esters. There still are some esters that we use in dental practice, but they're topical type of anesthetics. So the only injectable types of anesthetics that we use now are amides. And these here are the most common ones that we'll use. So in the office we have in the clinic we have lidocaine, we have bupivacaine, and we have articaine. Bupivacaine is a very long-acting medication, and then prilocaine we don't have the injectable prilocaine. We're going to learn later on, I think that's next week, that we do use something that does contain prilocaine.
We only have those three?
We only have lidocaine, bupivacaine, and articaine in the clinic.
There's only three to choose from.
There's only three to choose from,
Really
yes.
nice.
Yes, and actually articaine is not going to be your first line choice. You're either going to use lidocaine or bupivacaine, and you're literally going to decide that based on if you want a vasoconstrictor or not. That's what's going to give you the decision. Yes?
Is that because the articaine is the one that acts like an ester?
Yeah, we'll get to that here in a little bit. Mia, we're going to have Mia teach this. All right, so we'll pretend that I'm holding a cartridge of anesthetic in my hand, okay? If we look at the solution that's in the cartridge, what we will find is the anesthetic, so whichever anesthetic I happen to have in my hand. And that anesthetic is going to be in the form of a hydrochloride. So it's got hydrochloric acid added to it. There's going to be distilled water in the cartridge. And then depending on the pH of that anesthetic, sometimes more hydrochloric acid is added to it if the pH is too high. So it helps to bring the pH down. There's also sodium chloride in it. And that sodium chloride helps to make this solution more isotonic with the tissues because our tissues have sodium chloride in them. If the anesthetic contains a vasoconstrictor, then it has to have a preservative in it. And that preservative is sodium bisulfite, or sometimes it's referred to as sodium metabisulfite. Bisulfite. Bisulfite. All right. Now, if the anesthetic is a multi-dose vial, which we don't use, but anesthetics can come in multi-dose vials. And if they do, then they have to contain an antibacterial agent in them because they're used on multiple people. Now, obviously, if you stick a needle in it and remove some of the anesthetic, use it on someone and stick that same needle in it, you'll never use that on another person. But, you know, like in surgery, if with certain medications come in multi-dose vials, if you just stick a sterile needle in it and pull the solution out and then put the vial back on the counter to be used on someone else, there'll be an antibacterial agent in it just to protect it from the possibility that that some sort of a bacteria was introduced to the anesthetic or to the solution. We do not use multi-dose vials, we use the cartridges, okay? So our cartridges do not contain methylparaben. They do not contain antibacterial agents because they are single dose. So if we look at the molecular structure of an anesthetic, there are 3 parts to it. First, there's this aromatic ring. Secondly, there's an intermediate chain, and then there's a terminal amine. The aromatic ring is going to determine how lipid soluble that anesthetic is. And remember that the cell membrane has lipids in it, and so something has to be, the more lipid soluble something is, the easier it can pass through the cell membrane. So if we have an anesthetic that is highly lipid soluble, it's going to be able to enter the cells much faster than one that is not as highly lipid soluble. The intermediate chain is just going to determine whether the anesthetic is an ester or an amide. So again, we do not have any injectable esters. All of our injectable anesthetics are amides. We do have esters that we use in dentistry, but those are like the topical. The benzocaine, for those of you who know that you put the little topical on before you give the injection, that's an ester. And then the terminal amine is just considered an on-off switch. The terminal amine is, if it collects a hydrogen ion, then it becomes the ionized form. If it doesn't have the hydrogen ion, it is the neutral lipid soluble form. And we'll look at that here in just a minute. So it's just an on-off switch. If it has a hydrogen, it is the ionized water-soluble form. If it doesn't, then it's the neutral base lipid-soluble form. So when we look at the neutral base is considered the tertiary form. If this is the terminal amine right here, you see how there's a hydrogen added to it? Once that hydrogen is added to it, it is now the ionic form, which makes it water soluble. And this is the quaternary structure. So tertiary is the neutral base, lipid soluble. Quaternary is the ionized base, water soluble. And that's important for when we are injecting these anesthetics, how well these anesthetics are going to be able to enter the cell. And then again, that terminal amine is considered an on-off switch because if it has the hydrogen, or if it doesn't have the hydrogen, it's the lipid soluble form. If it has the hydrogen, it's the water soluble form. So when we look at local anesthetic preparations, you do not have to memorize these, okay? We're just going to look at the neutral base and the ionized form. Don't memorize this chemical formulation. So when companies make local anesthetics, they take the anesthetic, they add the hydrochloric acid, and they add the water, the distilled water. They're going to put that into the cartridge. When they put it into the cartridge, what will happen is the hydrogen from the hydrochloric acid will bind to the anesthetic so that the anesthetic in the cartridge is now the ionized water-soluble form. That doesn't help us because we need it to be in the lipid-soluble form to get through the cells. So something has to change once it gets into the body, and luckily it does. So when we inject it into a person, the pH of the human body is approximately 7.4, unless there's some sort of an inflammatory or infective process going on. The body is at a 7.4. So once it gets injected into the body, oh, okay, it's over here.
You know, I totally forgot I was recording the lecture.
Oh.
So I made it out there for that girl, because I have a habit of leaving it in the bathroom sometimes. Sorry about that.
That's okay. So once the anesthetic is injected into the body, which is at a 7.4 pH, some of the solution will remain in the ionized form, but some of the hydrogens will break off, and we now have the lipid-soluble form. So the lipid-soluble form, this is the part that's going to be able to enter the cells in order to stop or block the sodium from entering the cell, and which then will stop the cell from being able to depolarize.
What causes the hydrogen?
It just, because of the pH of the body. We're going to look at it a little bit further here in a second, because we're going to start talking about pKa here in just a second. All right, so just at this point, what we're looking at is we inject the solution into the body. At this point, the solution is all ionized. In the cartridge, it's all ionized, it's all water soluble. We introduce it to the body, we inject it into the body, and because of the pH of the body, a portion of that solution will lose the hydrogen, and that portion will be the lipid-soluble form. All right, so this is the way the anesthetic works. Here we have the cell membrane. Here's the extracellular environment. Here's the intracellular environment. This is a sodium channel. So normally sodium can go through that channel and the cell depolarizes. All right? When we inject the solution, remember the solution is in the water-soluble ionized form. It enters the body with a pH of 7.4, and some of that solution, the hydrogen, will break off, and we now have the lipid-soluble base. The part that is in the lipid-soluble base can enter through the cell membrane because it's lipid-soluble. Once it enters into the cell, what's going to happen is it's going to collect a hydrogen ion from inside the cell, and it's now water soluble again. So we needed to have it lipid soluble just to get it into the cell. But for it to block the channel, it has to be in the ionized form. So the lipid-soluble part comes through, it collects a hydrogen from the cytoplasm of the cell, and it is now the ionized water-soluble form. This will block that sodium channel now. So we have blocked it from the inside. So now if we get another stimulus, sodium tries to enter the cell, but it can't because it's been blocked by this. So therefore, if it's blocked, the cell cannot depolarize. Is everybody following that? All right, it goes from ionized, enters the body, portion of it becomes lipid soluble, the neutral base, which can enter the cell. Once it enters the cell, it adds a hydrogen from the cytoplasm. It becomes ionized again. It blocks the sodium channel. Now the sodium cannot get in. Now once that neutral base is able to enter the cell, then another hydrogen will break off of one of the ionized that are still, remember we said a portion of it is ionized, a portion of it is the neutral base. So once that neutral base is used, then more hydrogen will break off of some of the ionized so that we have more neutral base so that it can continue to keep working. Okay? Everybody following me? Yeah, okay. All right, so now we're going to look at pKa. And pKa is just an ionization constant. Okay? Basically what it is, or actually what it is that it's the pH where if you inject a solution into something, 50% of that solution will be in the ionized form, and 50% of that will be in the lipid-soluble form. So if we injected an anesthetic into the body, we know that the body is a 7.4 pH. So if that anesthetic had a pH of 7.4, I'm sorry, a pKa of 7.4, when we injected that solution into the body, 50% of it will be ionized and 50% of it will be neutral base. There is no anesthetic that has a pKa of 7.4. Okay? So we will never have a 50-50 mix when we inject an anesthetic into a body. All right, so the pKa again is the ionization constant. So it's the pH where when we inject whatever anesthetic we inject, 50% of it would be the neutral base and 50% of it would be ionized. And I had already mentioned if the pH of the body is 7.4 and the pKa of the solution is 7.4, then we would have a 50-50 mix.
You said it's not never 50-50.
There is no anesthetic that has a pKa of 7.4. The closest one is mepivacaine, so we're going to look at that one. All right, so here we have mepivacaine. So we know that neutral pH is 7.0, right? So anything above that is alkaline, anything below that is acidic, right? That's neutral pH. 7.4 is the body's pH. So the body's pH is just slightly alkaline. The pKa of mepivacaine is 7.6. So the pH would have to be 7.6 in order for it to be a 50-50 solution of ionized and neutral base. But it's not. It's 7.6 and the body is 7.4. So if for some reason the body was more alkaline and it was a 7.6 pH, then it would be 50-50. Because it's not and the body is a 7.4, only 39% of that solution will actually be in the lipid-soluble or neutral base form. You don't have to memorize these percentages. Just know the 50-50, okay?
So does that mean that drug specifically has more hydrogen atoms to break off?
I'm sorry?
Does that mean that some mepivacaine, does that mean that it has more hydrogen to break off?
No. It's because of the solutions themselves. The hydrogen actually has to be collected from something else. And so the hydrogen is just going to change, the hydrogen comes from the hydrochloric acid, which just changes the pH of the solution when it's in the cartridge. once it's in the body, it's related to the fact that we have a pH of 7.4 and the solution is 7.6, then not all of the hydrogen will cleave off. So a smaller portion of the anesthetic will have the hydrogen that cleaves off. So only 39% of it will have the hydrogen come off.
And that's what blocks.
And this is the part that we need to get into the cell. So because the pH of the body is not equal to the pKa, we don't have as much of the mepivacaine in the form that we need it to be in to get into the cell.
So then what happens to the other 64%?
Well, what will happen is as we use this up, then some will cleave off of this and get in, but it's not as fast. The onset is not going to be as fast as it would if we had an anesthetic that actually had a 7.4 pH. The onset would be almost immediate. Okay.
So does mepivacaine last long, or is it not long?
It does. It's not related to duration.
Okay.
It's just the onset.
Okay.
And we'll look at that here in just a little bit.
Okay.
So, what if the body was a 7.0?
It would be a fast onset.
If the body was less,
It would be even longer onset?
it actually is no onset, because if it's at 7.0, mepivacaine will not convert at all. And so think about when someone has an infection and you're trying to anesthetize that tooth. When you have an infection, the environment is acidic. So therefore, you're getting to this lower pH. And what happens sometimes, we anesthetize the person, we can't get them numb. And that's because of the pH in the environment is not allowing the anesthetic to convert. Okay?
So what would you do?
Well, typically what you'll do is you have to either continue working on them and they're going to feel it, depending on how serious the infection is. You may have to knock them out in order to work on them, or you may put them on antibiotics and bring them back. And so you put them on antibiotics for a few days and then bring them back. We've raised that pH a little bit because we've kind of taken care of some of that infection with the antibiotics, and then hopefully we'll be able to inject them. Now, if you're doing a block on someone, it's a little bit easier to get someone numb with a block than it is with an infiltration. Because if, say it's an anterior tooth, lower anterior, that's infected, we're blocking back here. So we're blocking back where the pH is still the normal pH. But if the infection was here and I'm trying to numb with an infiltration, I'm not catching that. And so it's much more difficult to get them numb. Okay? So again, if the pH of the body is 7.4, mepivacaine has the closest pKa to the body's pH. But even at the body's pH, only 39% of that will convert at any one time. All right, so if we look at the pKa's, and this is important to understand, not necessarily memorizing the numbers. You don't have to memorize the percentages. You don't necessarily really need to memorize the numbers. Just realize that there are anesthetics that have a pKa closer to normal body pH, and then you have some that are not, okay? So I want you to know which one, kind of know the order, but not necessarily memorize the numbers. I'm not going to say what's the pKa of Procaine. But I might ask you about which one will have the faster onset. Would Procaine or lidocaine have a faster onset? Lidocaine. All right, so there are some certain factors that will help to determine the clinical performance of the anesthetic. Now, the thing that you need to remember is that these things don't live in silos. So if you had two anesthetics that were exactly the same, except one was more lipid soluble than the other. The one that's more lipid soluble is going to be more potent. You wouldn't need as much of it. The thing to remember is there's other things that are going to come into play with it. And so manufacturers manipulate these anesthetics so that now every cartridge that you have is equal potent. So whether you have a Marcaine, or you have a Mepivacaine, or you have a lidocaine, even though the lipid solubility is different for each one of those, because the other things have been manipulated by the manufacturers, the Marcaine is just as equal potent as the lidocaine, which is just as equal potent to the Mepivacaine. Okay? So these are only if these things, if everything else was the same except for this thing, then the one that is more lipid soluble would be more potent. If everything was the same and one was more bound to protein or had a higher percentage of protein binding, that's going to determine the duration. Again, we can manipulate that by increasing the amount of the percentage of the solution or adding vasoconstrictors. There's other things that can be added to it or changed to change that duration. But everything else being equal, the more highly protein bound a solution is, the longer the duration of the anesthesia. The same thing with the pKa. The closer the pKa is to the normal pH of the body, which is 7.4, the faster the onset. And then the chemical linkage just means, is it an ester or is it an amide? The chemical linkage is going to determine how that medication is going to be metabolized. So looking at time of onset, again, the time of onset is going to be determined by the amount of the anesthetic that is in that neutral form or the lipid soluble form, because that's the part that needs to enter the cell. So again, if everything else is the same, the pKa is going to help you determine which one is going to have a faster onset, if everything else is the same. Other things that can affect it is the degree of lipid solubility. The concentration. I had mentioned if we have a higher concentration of solution, we can have a faster onset because we have more anesthetic available. The volume. If I give one cartridge of one anesthetic and I give 4 cartridges of another anesthetic, I have much more volume of anesthetic at that site. So therefore, there's going to be more anesthetic, even if it's a lower, if it's a higher pKa, we would expect it to be a slower onset. But if I have more of it, then in the end, I still have more anesthetic in the neutral form, even though it's a less percentage. Does that make sense? Did I lose you guys? Do you want me to explain that again?
Yeah.
Okay. So we know that Mepivacaine has a pKa of 7.6. It is the closest to the pH of the body. If I gave one of the other anesthetics that has a higher pKa, with everything else being equal, the Mepivacaine would have a faster onset. Correct? Because it's closer to the body's pH. But if I only give one cartridge of the Mepivacaine and I give 4 cartridges of lidocaine, even though less of each one of those there's less of each one of them in the neutral base, because I have such a higher volume of it, there's still more anesthetic in the neutral base. Does that make sense? Because it's just, we're looking at volume. So if you have 39% of one cartridge, or you have 25% of 4 cartridges, just because of the sheer volume, you have more anesthetic in that neutral base. But if I gave one cartridge of each, then I have more of the pivocaine. Okay?
So the onset of provocaine and pivocaine will be the same onset if you give more of provocaine?
Yes. But you have to be careful because there is maximums that you can give. And that, again, everything else being equal. But unfortunately, everything else isn't equal. All right, so the pH of the anesthetic solution. If you add a vasoconstrictor, you add epinephrine to the anesthetic, it lowers the pH. And the pH of the tissues, we already talked about that. If you're in a more acidic environment, then much less the anesthetic will be able to be in the neutral form. And the blood supply. If you inject in a highly vascular area, then there's more blood vessels available to take that anesthetic away. And then physical barriers as well. If you have a large diameter nerve, then you need a lot more of that anesthetic to be able to get all the way to the inside where, those inner neurons. So you may be anesthetizing the outside neurons, but not reaching the inside ones. So that diameter, you would end up having to give more solution in order to get enough anesthetic to be able to get those inner neurons. The denseness of the tissue. You've got to have, when we inject that anesthetic, we're not injecting it into a neuron. You're injecting it into the general vicinity of neurons. And so depending on how dense that tissue is, it's going to have to be able to get through that tissue to get to the neuron. So again, we know about the epineurium around the nerve, the periosteum, if we're trying to get it we need that anesthetic to be absorbed through the bone, like in the maxillary region, and the thickness of the cortical plate again. Okay, so let's look at binding to plasma proteins. We said binding to plasma proteins is going to affect the duration of the anesthetic. So here we have two drugs, drug A and drug B, and each one of these little squares are the molecules of the drug. The little squiggly lines are the plasma proteins. So with drug A, 50% of that drug is bound to the plasma proteins. So the 50% that is not is available to get to the tissues. And then as it's used up, then more can break off of these plasma proteins to go to the tissues. So because it is bound to those plasma proteins, it's going to be able to, the anesthetic is going to be able to last much longer because you're going to have the anesthetic molecules available much longer. With drug B, only 25% of that drug is bound to plasma proteins. So the molecules that are necessary to get to the tissues, but there may be molecules left over that are not bound to anything, and those are just going to get eliminated by the body. And so we have much less molecules left over that can be used once the original molecules are used up. So the duration of this anesthetic is going to be much shorter than the duration of this anesthetic because this one is more bound to plasma proteins. So there's going to be more available when it's needed. All right, so when we look at protein binding, local anesthetics bind to a specific glycoprotein called AAG. And when you get binding, that protein binding at the injection site, what's going to happen is that less of that molecule is going to be able to be washed away through the bloodstream and again eliminated from the body. So the result will be you'll have an increased duration of the anesthetic, again, everything else being equal. If you add a vasopressor to another anesthetic, it may last longer because of the vasopressor action. But with everything else being equal, the duration is going to be longer for the one that's more protein bound. Now there are some things that can affect protein binding. So the things that can increase it are if you have trauma, cancer, surgery to the area, or chronic pain. Factors that can reduce binding are pregnancy, oral contraceptives, and hormone replacement therapy. So women, hormonal women, the anesthetic doesn't last as long because it's less protein bound. All right, so this graph or this table will show you the different, if you're looking at the different pKa's, you're looking at the onset of the anesthetic and how protein bound it is and the duration of that anesthetic. Now, when you look at some of these tables, they may be a little different because I use different articles or your book or something, so sometimes the numbers are off just a little bit, but I want you to just get the gist of this. I don't want you to memorize that lidocaine's onset is going to be 2 to 4 minutes, okay? You just need to understand that there are some that'll have a faster onset, and the onset is based on, again, all things being equal, it's based on the pKa. Not everything is equal, and that's why we have 4 of them that have the same onset.
Can you say that again?
I said that I don't want you to memorize, the onset. I don't want you to memorize that lidocaine is going to have an onset of 2 to 4 minutes. But what this is showing you is that when you look at the pKa's, you would expect this one to have the fastest onset and this one to have the slowest onset. And in general, you're seeing that. The thing is that the reason you're seeing the same onset with these 4 is because of other factors that came into play with that anesthetic. So different things that the manufacturer has done to the anesthetic to change that. And that's why they all have about the same. But these still, the higher pKa ones do have it takes longer for the onset to occur. Then when we look at the protein binding, the more highly protein bound it is, the longer the duration you would expect. Again, because of manipulation of the anesthetics, not everything is equal anymore. And so these numbers are going to be a little different, but you can see this one only has 5% protein binding, and its duration is much shorter than the duration of the other ones.
That one takes the longest to kick in and lasts the shortest?
Yes. Yep. All right. Let's do some math. Okay. When we look at a solution, or when we look at an anesthetic cartridge, it's going to tell you it's a 1% solution, or a 2% solution, or a 4% solution. When you look at that solution, what the percent means is that there is a specific number of grams of that anesthetic in 100 milliliters of solution. So if you have a 1% solution, a 1% solution means that if you had 100 milliliters of an anesthetic solution in your hand, 1 gram of that solution would be the actual anesthetic. We know that there's water added to it and all other kinds of things added to it. So a 1% solution has 1 gram of anesthetic in 100 milliliters of that solution. So how many grams would a 2% solution have?
2 grams.
2 grams. How many grams would a 0.5% solution have? Half a gram. Good. So, the rule of thumb to remember, this is something you want to memorize. A 1% solution is equal to 10 milligrams per milliliter. The way we determine that is we have 1 gram is 1,000 milligrams. So we have 1,000 milligrams in a 100 milliliter solution. Well, our cartridges don't have 100 milliliters in them. So we can solve, if we have 1,000 milligrams to 100 milliliters, we would have 10 milligrams to 1 milliliter, right? So a 1% solution has 10 milligrams per milliliter. 2% solution has 20 milligrams. 0.5% solution has 5 milligrams. Good. Now, when you look at the cartridges, and this is probably going to be different the way you document in the office compared to how we're going to have you document here. I want you to assume that all cartridges have 1.7 milliliters in them. We know that they don't. Lidocaine has 1.8. But your board exam uses 1.7. So that's why I want you guys to remember 1.7. When you get into the office, when you're working, they may want you to put exactly what it is. Some of them say 1 cartridge, which really bothers me. But just realize that some of the cartridges have 1.7, some have 1.8. Your board exam uses 1.7. When I show you some of the math, because they came from actual articles, some of them actually use 1.7, some of them use 1.8, so the numbers may be a little off, but when I ask you the questions, I'm going to ask you in whole numbers, so you don't get confused when I ask you the math, okay? All right, so we're going to assume that all cartridges contain 1.7. So here, let's do some math. How many milligrams of anesthetic are contained in 2 cartridges of 2% lidocaine? What's the first thing we got to think about?
Maybe 20 milligrams.
We've got, if 1% is 10 milligrams per milliliter, then 2% is 20 milligrams per milliliter, right? Yeah. And we know that a cartridge contains 1.7 milliliters, so 2 cartridges would be 3.4 milliliters, right? So we know that we have 20 milligrams per milliliter, and we have 3.4 milliliters, so therefore, if we multiply the 2, we have 68 milligrams of anesthetic in 2 cartridges of 2% lidocaine. Does everybody see how I got that? All right. Yes. We know that it's a given that 1% solution contains 10 milligrams per milliliter. So therefore, a 2% solution would contain 20 milligrams per milliliter. We're trying to determine how much is in 2 cartridges. We know that 1 cartridge contains 1.7 milliliters of solution. So 2 cartridges would contain 3.4 milliliters of solution. So if we have 20 milligrams of anesthetic in 1 milliliter of solution, and we have 3.4 milliliters of solution, we can multiply 20 times 3.4, and we get 68 milligrams of anesthetic in 2 cartridges of 2% lidocaine. All right, so let's do some practice questions. We have 3 cartridges of 2% carbocaine or mepivacaine with 1 to 20,000 levonorepinephrine. We haven't talked about vasoconstrictors yet, so we can just ignore that. How many milligrams of anesthetic would you find in 3 cartridges of 2% carbocaine? 102? You want to tell them how you figured that out?
So 3 cartridges, so that would be 127, right? Yeah, 3. So you 1.7 times 3, and then 2% means 20. You just multiply.
The 5.1 times 20, right? Everybody following that?
Can you say that one more time?
Yes. Okay, so we know that 2% carbocaine would contain 20 milligrams per milliliter of anesthetic. We have 3 cartridges. Each cartridge has 1.7 milliliters. So 1.7 times 3 is 5.1. So we multiply the 5.1 times 5.1 milliliters times 20 milligrams per milliliter, and we get 102 milligrams. All right, so now we have 4 cartridges of 1.5% Duranest. So When we have 1.5, how many milligrams do we have per milliliter? 15. And we have 4 cartridges at 1.7 each. So what's 4 times 1.7? 6.8. So what's 6.8 times 15? So they're both the same.
Beyond I get there.
Okay? All right. 7 cartridges of 4% septicane. 4% would contain how many milligrams per milliliter? 40. 7 cartridges times 1.7 milliliters is what?
11.9.
11.9 times 40.
476.
He's cheating.
Cheating? Dr. Gibson, you better let us use a
Are we allowed to
calculator.
have a calculator?
You will, yeah. Normally with the lockdown browser, you can have a calculator, but yes, you can have a calculator.
Oh, thank you so much.
Yeah, actually, you're going to use the calculator on the computer. You're not going to use your phones.
Okay.
That's fine.
Okay. All right.
Can you use the calculator on the board?
I don't know. That's a good question. All right, 6 cartridges of 0.5% Marcaid. How many milligrams per milliliter? 5. Okay, 6 cartridges times 1.7. 10.2. 10.2 times 5.
Yeah, it's 51.
51. 4 cartridges of 2% lidocaine. 2% is 20. 4 cartridges times 1.7. 6.8 times 20.
176.
Good.
So the second half of all those were as the 1 to whatever.
We're gonna deal with that next week. Yeah. Yeah.
Does it like affect the answer at all?
This does not affect this answer at all. No, because we're just trying to determine the amount of anesthetic. Now, this is going to affect, when we look at it, how much anesthetic we can give to a person based on whether it has a vasopressor in it or not. And we'll look at all of that, tie that in next week. All right, so in the U.S., we have several local anesthetics that we can choose from. We have short-acting ones, intermediate-acting ones, and long-acting ones. So mepivacaine, there's 2 different types of mepivacaine. There's one with a vasopressor, there's one without. The without is a 3% solution, and so it's short-acting because obviously it doesn't last as long because there's no vasopressor in it. The prilocaine 4% without vasoconstrictor, if we're using it as an infiltration, is considered short-acting. If we use it as a block, then it's considered intermediate acting. So the ones that we use in the dental center are mepivacaine 3%. We use the lidocaine 2% with 1 to 100,000 epinephrine. We'll talk about the epinephrine next week. And then we have the 4% articaine with 1 to 200,000 epinephrine. Those are the 3 that we have in the clinic. The long-acting one is bupivacaine, which is Marcaine. That's the one we give after we've done, 4 third molars. We've done a really hairy endo on them. We'll give them some Marcaine to keep them numb for a good 6 to 8 hours afterwards. All right, so now we got to look at some systemic effects that can occur with local anesthetics, because if we give too much, we can cause toxic results. So when we look at the side effects of anesthetics, the most serious ones are related to the central nervous system. And so when we look at how anesthetics are metabolized, again, I said esters and amides are metabolized differently. Esters are metabolized in the blood. So we have cholinesterases in the blood that will break down the anesthetics, and then we excrete them through the kidneys. Occasionally, some anesthetics do not get broken down, and we just excrete them through the kidneys. The amides are broken down in the liver. So we have enzymes in our liver that are going to break them down, and then we excrete them through the kidneys. So all of the injectable anesthetics that we use are amides. So they're going to be broken down by enzymes in the liver. The esters are topicals. So the benzocaine topical is going to be broken down in the plasma. There's one exception to that, and that's articaine. Articaine is broken down both ways. Articaine is an amide. It is not an ester. It is amide, but for some reason it is broken down by the liver and also in the plasma by cholinesterases in the plasma. So once the anesthetics have reached the bloodstream, they're going to go through the same process as any other drug. So they're going to be distributed through the body, they're going to be biotransformed or metabolized, and then they're going to be eliminated. We already mentioned they're eliminated by the kidneys. So when we look at the serum concentration of an anesthetic, we got to look at the rate of absorption of that anesthetic, and then we also need to look at the rate of metabolism and excretion of that anesthetic. Because if we have a high absorption of that anesthetic, there's not going to be as much in the blood. If we have a high rate of metabolism, there's not going to be that much in the blood. But if we have a low rate of those, we could actually cause toxic effects by having too much anesthetic in the bloodstream. So when we look at the elimination half-life, you've already learned about that. That's the time it takes for 50% of that anesthetic to be broken down. And then again, this is just a repeat from what you've learned before. If it has an elimination half-life of 2 hours, then every 2 hours it's going to be broken down by half or eliminated by half. And after about 4 to 5 half-lives, it's determined to be eliminated from the body. And then again, half-life is going to be determined or influenced by how lipid soluble the anesthetic is. The more lipid soluble it is, the more it's going to be absorbed by the body's tissues, and how highly protein bound it is. The more protein bound it is, it cannot reach the tissues, therefore you don't get as much of a toxic level. So this is just showing the half-lives of the anesthetics, and again, you don't need to memorize the actual numbers, but as you can see, with bupivacaine has a much longer elimination half-life. So when we look at those systemic effects of the anesthetics, and we're specifically looking at lidocaine in the blood. So at between 0 and 5, we can see that we can get a little bit of sedation, dizziness, you can have some anticonvulsant activity. The antiarrhythmic is a good thing. A lot of times when people have cardiac arrest and they shock them back, they had a shockable rhythm and they shock them back to a normal sinus rhythm, a lot of times they'll hang a lidocaine drip to hopefully prevent it from going back into that arrhythmia. But we can see as the level increases, the effects start to increase. And then at some point we can we can put an individual in a coma, or they could have respiratory arrest, and eventually they can have cardiovascular collapse. And so you can kill a patient by giving them too much anesthetic. Okay? This is a really important chart to know. This one tells you, and what I want you to really look at is this here. This is probably the most important thing on this entire chart, is the number of cartridges for an average healthy adult for the maximum recommended dose of lidocaine 2%. This is based on a 1.8 milliliter cartridge. If it was a 1.7 milliliter cartridge, this would be 8.8. But if I asked you in whole numbers, 8 cartridges would be the most that you could give someone. This is a really sad case report. This is about a 2.5-year-old child who went to the dentist for some restorative work. The child weighed between 46 and 48 pounds. The dentist decided to use Prilocaine 4% plain because it had, the dentist said was that it had a neutral pH, so it was less painful to give the injection to the child. Okay? So they wanted to use 4% plain on this individual. The child received 5 cartridges. Okay? We go back to this chart. We look at Prilocaine. For a 50-pound child, 1.8 cartridges is the maximum recommended dose. Okay? So this child got 5 cartridges. Plus, this was plain, so it had no vasoconstrictor in it, so it immediately was able to get into the bloodstream. So, if you look at a 4% plain has 72 milligrams of anesthetic in the cartridge, gave him 5 cartridges, so this child received 360 milligrams of Prilocaine. Maximum recommended dose is 2.7 milligrams per pound, so a 50-pound child would be 135 milligrams. Again, 1.8 cartridges. So this dentist overdosed this child. The child began to have seizures and went into cardiac arrest. And by the time they made it to the hospital, they were dead.
How do you reverse something?
You can't. You cannot reverse stupidity.
So this really happened?
This really happened. This is a true case report.
So did that dentist lose his license?
Oh, yes. And more than that.
Yeah.
Yes. All right, so here's another thing. So if you look at these doses, these are a little different than that other chart. This, I want you to look at this because this is just looking at duration. And this is based on whether you give an infiltration or a block. And so the take-home message from this is when you give an infiltration, the anesthesia does not last as long as when you give a block. So that's basically the take-home message that you can get from this table. This was just looking at the relative pain. When they gave injections to individuals with these specific anesthetics and saline, they were doing a subjective test on what the pain level was that the patient had with each specific anesthetic. We know that it's not the needle penetrating the tissue that causes the pain. It's the solution as it's being put in. And if you look at this, interestingly enough, the one that caused the least amount of pain was lidocaine. They actually had more pain with saline than they did with lidocaine, and saline is completely isotonic with the body. So again, this is subjective, but yeah, this is what they found. Okay, hypersensitivity is rare. If it occurs, it's usually due to a preservative, not the anesthetic. But there are times that people are truly allergic to anesthetics. And so when someone tells you that they are allergic to Novocaine, because that's what they always tell you, you have to find out what the situation was, because we know it wasn't Novocaine, unless they're maybe 85 years old. Maybe they did have Novocaine. But usually it's not an actual hypersensitivity reaction. It's usually either going to be they had some sort of response from the vasoconstrictor or the vasopressor. You know, the epinephrine sometimes can make your heart beat a little faster. And so sometimes it's like, oh yeah, it made my heart beat really, really fast. Okay, well that's not a hypersensitivity reaction. That's a normal reaction to epinephrine. Did they have a vasovagal response? Oh yeah, I passed out as soon as they gave it to me. Well, that's not caused by the anesthetic. Could it be that there was some sort of an allergic reaction to, again, the preservatives in the anesthetic? If we find that they truly are allergic, sometimes they have to do allergy testing to determine that. But if it's found that they're truly allergic to all anesthetics, diphenhydramine or Benadryl is an option. You can anesthetize somebody with Benadryl. Sometimes you don't get as profound anesthesia, and if that's the case, then you have to take them to the operating room and knock them out to do their work. All right, let's go through the homework real quick.